this lecture we are going to discuss about pharmacology of calcium channel blockers. To understand the pharmacology of calcium channel blockers, we should understand what are the functions of calcium inside the body. First function is it is one of the important second messenger pathway inside the cell. It helps in signal transduction of the various cells, and as we have learned in general pharmacology, it is one of the important second messenger pathway for different cells. Calcium is one of the important substance which is responsible for neurotransmitter release from neurons. If you remember from the lectures of the autonomic nervous system, calcium entry is essential for the vesicular docking and release of vesicles to the surface of the neuron, which would lead to release of the neurotransmitter. So calcium has very essential role in neurotransmitter release from neurons. Calcium is also responsible for contraction of all muscle cell types. Many enzymes require calcium ion as a cofactor. Example is blood clotting cascade. So it is one of the essential component of that clotting mechanism also. Extracellular calcium is also important for maintaining the potential difference across the excitable cell membranes. So it will help in maintaining the cell membrane potential also. And as very well known that calcium is very important for proper bone formation and maintenance of bone health. Now we see the functions of calcium in little bit more detail. First function is contraction of the smooth muscles. This is the diagram showing the smooth muscle. Here you can see that action potential enter from the adjacent cell, and it will action potential will open the calcium channel which is located on the smooth muscles. Voltage gated calcium channels open and calcium ion enters inside the cells. Entry of calcium will trigger the release of calcium from the sarcoplasmic reticulum. So this calcium would act on the sarcoplasmic reticulum, and the release of calcium from this sarcoplasmic reticulum is stimulated, and most of the calcium comes from the sarcoplasmic reticulum. This calcium ion bind to the troponin to initiate the contraction. Once the contraction is taken place, the process of relaxation starts. The relaxation occurs when calcium ion unbinds from the troponin. So binding of calcium to the troponin will stimulate the contraction, and unbinding of the calcium from the troponin will stimulate the relaxation. So that would lead to freeing of calcium ion from the troponin. This calcium ion is pumped back into the sarcoplasmic reticulum with the use of ATP, which is the active process, and rest of the calcium ion will be pumped out into the extracellular fluid in exchange with the calcium. There is a calcium sodium exchanger mechanism located on the cell, and once this calcium ion goes out in for the exchange of sodium which comes in, but sodium ion will be again exchanged with the potassium, because most common extracellular ion is the sodium and most important intracellular ion is the potassium. So this ionic gradient is usually maintained by sodium potassium ATPase enzyme, which leads to entry of potassium inside the cell and exit of sodium into the extracellular fluid. Now we see the function of calcium onto the cardiac action potential. Cardiac tissue is of two varieties. One is either ventricular myocytes or atrial cells, and other is the SA node or AV node. Here into the myocytes, the calcium ion is responsible for the play-to phase of action potential. If you remember the physiology of cardiac action potential, it has four phases. Into the first phase or the phase 0, there is opening of the sodium channels, and sodium ion goes inside the cell, which lead to initial depolarization, followed by opening of the potassium ion and opening of the calcium channel, which would lead to maintenance of this contraction called as play-to phase. And into the third phase, there is opening of the potassium ion, which would lead to an exit of the potassium outside the cell called as hyperpolarization, and phase 4 is the resting phase or the phase of delayed depolarization. But here the second phase or the Plato phase is maintained with the calcium ion. While the scenario is little bit different into the SA node and AV node, here into the SA node and AV node, the whole action potential is dependent on the calcium instead of the sodium ions. So here the calcium ion is there into the phase 0 as well as phase 3, which is responsible for maintaining the automaticity of the cardiac SA node and AV node. We will be learning in detail about this action potential when we discuss the lectures of cardiac arrhythmia also. Now we focus on classes or types of calcium channels. Calcium channels are of different varieties, of which first is voltage sensitive or voltage gated ion channels, where movement of calcium is mediated through the change into the voltage of the surface. Second is receptor operated or ligand gated ion channels, where binding of a substance to the receptor is responsible for the calcium ion entry or exit from the cell. And third type of channels are called as leaky channels, where small quantity of calcium is released throughout, of which voltage gated calcium channels are one of the most important drug targets on which different drugs act. Voltage gated calcium channels are of three varieties: L type, T type and N type. L type also stands for long lasting current variety, T stands for transient current and N stands for neuronal type. If we see the conduction, L type of voltage gated calcium channels has 25 ps of conduction, T type has 5 ps and N type has 12 to 20 ps. Activation threshold is very high for L type of calcium channel. It is low for T type and medium for N type of calcium channels. Inactivation rate is very slow with the L type of channels, while it is fast with the transient current and medium with the neuronal channel. Location and function of L type of calcium channel is excitation contraction coupling in cardiac and smooth muscles, SA node and AV node related to conductivity, endocrine cells where release of hormone is responsible, and neurons where neurotransmitter is going to be released. T type of calcium channels are located into the SA node for pacemaker activity. T currents and repetitive spikes in thalamus and other neurons is responsible for maintaining neural activity. Some T type of calcium channels are present into the endocrine cells and others are present into certain arteries responsible for constriction and all. While neuronal type of calcium channels are present only into the CNS, neurons related to sympathetic ganglia. It is also present into the myotonic plexus, where it is responsible for release of the neurotransmitter. And calcium is a common agonist at all the channels. If we see the blockers or the drugs which can block these channels, L type of calcium channels can be blocked by nifedipine, Verapamil and Diltiazem like drugs, while T type is blocked by flunarizine and ethosuximide, and N type is blocked by W-contoxin. Now we come to the actual pharmacological classification of calcium channel blockers, also known as CCBs. First chemical classification is diphenyl alkylamine group, that include Verapamil, benzothiazepine group, that include Diltiazem, and dihydropyridine, of which first generation dihydropyridine is nifedipine and second generation are amlodipine, phalodipine, isradipine, nicardipine, nisoldipine and many more are there in market. If we see the mechanism of action of calcium channel blockers, they basically block the calcium entry into cardiac and vascular smooth muscles by combining at the alpha 1 subunit of the L type of voltage gated calcium channels. They are the slow channels as discussed earlier. They increase the time for which calcium channel remains closed, which means they enhance the time for which calcium channel remains closed. So ultimately opening of the calcium channel is reduced and calcium entry inside the cell is inhibited. Here you can see that regulation of voltage dependent calcium channels. Here it is into the closed state when they are transmembrane channel and the ion passing through is the calcium. When whenever there is depolarization, this channel gets opened because it is voltage sensitive. So depolarization will change the membrane potential. That voltage change will open this calcium channel and allow the entry of calcium inside the cells. Once this calcium inside the cell, the channel becomes inactive. Okay, it is closed from both the sides, and the channel remain into this inactive stage for a bit period of time. Then it goes into the phase of closed channel, where it cannot be activated by the depolarization. That is called as repolarization phase, and this phase is prolonged. That is the time in which the calcium channels remains into the closed phase. That time is prolonged with the calcium channel blockers. So the closed time of the channel is higher as compared to the open time. Now we see the pharmacological actions of calcium channel blocker. Of course, the first actions would be on cardiac tissues. On SA node, it causes suppression. It decreases the pacemaker activity of the heart and decreases the heart rate. Action on cardiac myocytes. Calcium enters during the plateau phase of action potential in myocytes, causing intracellular calcium release and contraction. The inhibition of this contraction would lead to reduced force of contraction, and reduced cardiac output has been noticed with calcium channel blockers. So calcium channel blockers have negative inotropic action. They reduces the force of contraction of cardiac myocytes. What is the effect on SA and AV node and its conductivity? Calcium mediates depolarization or phase 0 into SA node and AV node. So automaticity and conduction, both of the SA node and AV node, depends upon the rate of recovery of the calcium channels. So CCB delay the channel recovery and inhibit the automaticity and conduction velocity of these nodes. The effect is highest with the Verapamil, followed by Diltiazem, and dihydropyridine group are having no such kind of effect. That is why Verapamil and Diltiazem are effective drugs as anti-arrhythmic activity. Other pharmacological action is on vascular smooth muscles. They are called as vascular actions also. Depolarized by inward calcium movement, causing intracellular release of the calcium, lead to contraction of the vascular smooth muscle. Whenever we give calcium channel blocker, they cause relaxation by blocking the calcium channels. But these vascular actions are highest with the dihydropyridine, followed by Verapamil, and third is Diltiazem. Which means Verapamil is having highest cardiac action, Diltiazem is intermediate, and dihydropyridine does not have cardiac action. While vascular actions are highest with dihydropyridine, Diltiazem is intermediate, and it is least with the Verapamil. It has marked effect on the arterioles as compared to veins. It reduced more after load than preload because it is acting on arterioles. Decrease in the total peripheral resistance is seen, so ultimately there is the reduction into the diastolic blood pressure is noticed. Reduction in BP is accompanied by tachycardia in case of nifedipine, but not with the Verapamil, because sudden fall into the blood pressure will activate the baroreceptor and chemoreceptor trigger zone, and ultimately compensatory tachycardia would be there, which is highestly seen with the dihydropyridine group of drug, that of the immediate release. But sustained release preparation does not have this side effect. They relax systemic as well as pulmonary blood vessels also. They also dilate the coronary arteries. Other action on the other smooth muscles is mentioned here. It causes relaxation of all the smooth muscles because contraction is inhibited. It causes relaxation of bronchial smooth muscle, biliary smooth muscle, intestinal smooth muscles, vesical smooth muscles, and uterine smooth muscles also. It relaxes the upper and lower esophageal sphincter and may lead to worsening of the GERD patients. So if we have to combinedly mention the pharmacological actions of calcium channel blocker, they are the basically actions on the heart and on the cardiovascular system, other vascular system. On the heart, on SA node, it decreases automaticity. AV node, it decreases conduction. On cardiac myocyte, it decreases afterload, decreases force of contraction, decreases cardiac output, and decreases myocardial oxygen demand. On coronary artery, it causes increased vasodilatation and increased myocardial oxygen supply. It mainly acts on the arterioles and produces vasodilatation, decrease in the afterload, and decreased myocardial oxygen demand by causing vasodilatation of arteries. And peripheral veins also get dilated, but that is minimal action. So it is mainly having actions on the heart as well as on the arterial system. Now we compare different calcium channel blockers available in market. Chemically, we have three classes: diphenylalkyne, that is verapamil; benzothiazepine, that is diltiazem; and dihydropyridine, that is nifedipine; and second generation dihydropyridine, that is amlodipine. SA node depression, that is the cardiac action, it is highest with the verapamil. Diltiazem is having intermediate action, and DHPs, dihydropyridine, does not have any of the cardiac action. Force of contraction is reduced highest with the verapamil, then diltiazem, while nifedipine amlodipine does not have that action. Blocking of AV conduction highest with verapamil, intermediate with diltiazem, while nifedipine and amlodipine does not have this action. Vasodilatation is prominent with the nifedipine and amlodipine group of drug, while it is less with the verapamil and very less with the diltiazem. Heart rate with the verapamil decreases. With diltiazem, either it remains normal or decreases, and with nifedipine it is increased because of the reflex vasodilatation, which produces sudden fall in blood pressure, compensatory reflex sympathetic overactivity, and tachycardia. But while amlodipine and other newer agents does not have the problem of reflex tachycardia. So clinical uses: verapamil can be used for the pathology related to heart like cardiac arrhythmia, angina and hypertension. Diltiazem is also used for angina, hypertension and arrhythmia, while nifedipine and amlodipine are used for hypertension mainly, and amlodipine can be used for angina also. Now we see the individual drugs. First is verapamil. Cardiac action: reduced heart rate, reduced contractility, decreased AV conduction. Cardiac output is maintained by reflex sympathetic stimulation. In congestive heart failure, ventricular contractility is markedly impaired with the verapamil, so it should not be given to the patients of CHF. Vascular action: it dilates arterioles, but some alpha blocking action is also seen. It reduces total peripheral vascular resistance and reduces diastolic BP, while coronary blood flow is increased. Adverse effects are: cardiac related ADR are very common with the verapamil. It includes bradycardia, it aggravates the conduction defects and congestive heart failure, and cardiac arrest on IV administration has been seen into the susceptible individual and those with the sick sinus syndrome. Other common adverse effects are nausea, constipation, bradycardia, etc. And vascular side effects are mainly because of the vasodilatation. It includes flushing because of the vasodilatation of the cutaneous vessel, hypotension, headache because of the pulsatile vasodilatation of the arteries related to head and neck region, and pedal edema are less common. Drug interactions of calcium channel blockers should be kept in mind. Verapamil cannot be given along with beta blockers because verapamil will suppress the heart. It decreases the heart rate, decrease force of the contraction. The same action is seen with the beta blockers also. Cardioselective beta blocker will decrease the heart rate, decrease force of contraction. Ultimately, AV conduction is reduced. So when the two drugs, which are cardiac depressant, given together, there is a risk of complete AV block and sudden cardiac arrest is there. Therefore, verapamil should never be given along with the beta blockers, but you can give dihydropyridine group with the beta blockers. Raised digoxin level is seen with the verapamil. Other cardiac depressant drugs like quinidine and disopyramide will develop additional cardiac depression, which can be dangerous and should not be prescribed simultaneously. Next category is diltiazem. Cardiac action: decrease in the heart rate is equivalent to verapamil. Reduced contractility and decreased inotropic action is less than that of the verapamil. It decreases the AV conduction and depression of SA node and AV node. That action is almost equivalent to verapamil. In CHF, ventricular contractility is markedly impaired, so this drug should also not be used into the patients of heart failure. Vascular actions, if we see, vasodilator action is very less as compared to nifedipine and verapamil. It reduces total peripheral resistance, reduces diastolic blood pressure, and coronary flow is increased with the diltiazem. Adverse drug reaction, which is similar to verapamil but incidence rate is little bit low. Cardiac related adverse drug reactions are bradycardia, aggravate conduction defect, and heart failure. Cardiac arrest on IV administration, especially into sick sinus syndrome patient. Vascular side effects like flushing, hypotension, headache, and ankle edema are less commonly seen, and it causes increased plasma digoxin level also. It is contraindicated to use into the patients with sick sinus syndrome and AV blockage. Precaution is required in patient taking beta blocker. Low dose can be given. Third category of calcium channel blocker is dihydropyridine. Prototype of that is nifedipine. Cardiac action are almost negligible. It has no effect on the SA node, AV node. It does not have any effect on contractility. Vascular action is predominated here. It dilates arteriole, it reduces total peripheral resistance and reduces diastolic BP. It produces reflex tachycardia. That's why increased contractility can be seen, and increased coronary blood flow is seen with the nifedipine. It also produces mild natriuretic action. What are the adverse effects of DHPs? Cardiac related adverse drug reactions are less common. Vascular ADR are more common. Reflex tachycardia is the most predominant problem. That is why it can be safely combined with beta blockers and digoxin, because beta blocker will suppress the heart while DHP will increase the heart rate. So ultimately they will nullify the effect of each other. So combination of beta blocker with amlodipine or nifedipine is a good combination, but beta blocker with verapamil is absolutely contraindicated. Palpitation, flushing, hypotension, nausea, headache, ankle edema, they are minimized by giving the drug at the low doses, and you should gradually increase the dose. Frequent doses and sustained release tablets can reduce such side effects. It can cause paradoxical increased frequency of the angina because of the reflex tachycardia, which can be dangerous. That is why in angina patient we only use amlodipine and others, not the nifedipine. Increased mortality has been reported sometimes into the patients, those who are post-MI, when they are given nifedipine sublingually because of the sudden tachycardia and death. It can produce difficulty in micturition in elderly males. It also causes inhibition of insulin release and interferes with the diabetic control also to some extent. Other subsequent drug developed after nifedipine are felodipine, which is longer acting, available as tablet of 2.5, 5 and 10 milligram immediate release. Tablet dose is 5 to 10 milligram once or twice a day. Amlodipine is another longer acting drug. It is having slow oral absorption, consistent high bioavailability, minimize the early side effect. Available as 2.5, 5 and 10 milligram tablets. Dose is 5 to 10 milligram to be taken once a day. And amlodipine is currently one of the most frequently used antihypertensive drug. Nitrendipine and lecidipine, they are similar to DHPs but longer acting. One special drug is nimodipine, which is a shorter acting dihydropyridine, but it is one of the having important characteristic that it is highly lipid soluble drug. High lipid solubility, which means it can penetrate the blood brain barrier well, and it has good concentration into the brain tissue as well as CSF. It produces selective cerebrovascular relaxation. That is why it is approved drug for prevention and treatment of cerebral vasospasm after subarachnoid hemorrhage or rupture of aneurysm. So when we want cerebrovascular relaxation, special action into the CNS, we use nimodipine because it is lipid soluble drug. Adverse drug reactions are headache, flushing, palpitation, dizziness, which are very common with nimodipine. Now we combinedly see the pharmacokinetics. All the calcium channel blockers can be given orally with the oral absorption of 90 to 100%. They have variable bioavailability depending on the variation into the first pass metabolism, but all of them are effective orally. They all are highly plasma protein bound. Peak plasma effect is seen with 1 to 3 hours, and amlodipine it is 6 to 9 hours. More than 90% of the drug is having hepatic metabolism. Half-life is ranging from 2 to 6 hours, with amlodipine is having around 45 hours of half-life, phalodipine is having 12 to 18 hours of half-life. Verapamil inhibits its own metabolism on continued administration, and bioavailability is doubled. Now we come to the therapeutic uses of calcium channel blockers. First use is hypertension. Second is angina pectoris. Third is cardiac arrhythmia. Fourth is hypertrophic cardiomyopathy. Fifth is premature labor. Sixth is nocturnal leg cramps. Seventh is Raynaud disease, that is one of the peripheral vascular diseases. Now we see each of them into detail. First use is hypertension. Calcium channel blockers are among the first line antihypertensive drugs for the management of hypertension. ABCD stands for AC inhibitors, beta blockers, calcium channel blockers and diuretic. These are the four first line drugs for the hypertension, of which A stands for AC inhibitors and angiotensin receptor blockers, that we have discussed. B stands for beta blockers, that also we have discussed. C for the calcium channel blockers. All calcium channel blockers are having equal efficacy. They act by blocking L type of voltage gated calcium channels, and vasodilatation, which is produced more into the arteries, that would cause reduction into the total peripheral resistance and ultimately cause lowering of the diastolic BP more than the systolic BP. They are having quick onset of action. Convenient dosage schedule is there of once a day or twice a day. Monotherapy is effective in controlling the blood pressure in 50% of patients irrespective of the plasma renin activity. Other advantages are they are safe to use in hypertension with asthma because they produces bronchodilation, and in asthma there is a disease where bronchoconstriction occurs. So if patient is having hypertension with bronchial asthma, calcium channel blocker are safe drug to use because they can dilate the bronchi also. They are safe drug to use into the patients with hypertension as well as peripheral vascular disease because they produces vasodilatation. In peripheral vascular diseases, peripheral vessels are constricted. This action can be inhibited by calcium channel blocker. They can also be used for the patient with hypertension with variant angina, where cause of variant angina is the constriction of the coronary arteries. No rebound hypertension is seen on the withdrawal. You can discontinue the drug at any time, unlike beta blockers. There is no postural hypotension and reduced renal blood flow is seen. No electrolyte imbalance, hyperuricemia or effect on lipid profile. Minimal or no effect on the quality of life or male sexual function is not affected. The drug is very safe during pregnancy and it does not have any CNS side effects. So these are the advantages of calcium channel blockers which make them drug of first line for the management of hypertension. Reports of increased mortality and reinfarction and worsening of the unstable angina with shorter acting dihydropyridines like nifedipine has been seen because of the reflex increase in the heart rate and cardiac output. That's why we use nifedipine, longer acting preparations only, sustained release tablets, or if at all we are going to use DHP, we use second generation, that is amlodipine and others which are longer acting drugs. Longer acting CCBs reduces cardiovascular morbidity. They do not provide post-MI survival benefit, but still they are very useful drug for the angina also. Worsening of the following conditions is seen with the calcium channel blocker, that is why they are contraindicated in them. First is heart failure. Because calcium channel blocker reduces the force of contraction, they should not be given into the heart failure where already heart is failed to contract. Second is conduction defect. Calcium channel blocker will aggravate this conduction defect, so it should not be used into the patients with conduction defects. It should not be used into the patients of GERD because it will aggravate the disease by relaxing the smooth muscle. Urine voiding difficulty in elderly male or benign prostatic hyperplasia will be worsened because of the relaxation of the smooth muscles. So in such condition, calcium channel blockers are contraindicated. Other use of calcium channel blocker is in angina pectoris, also called as coronary artery disease. They are useful for prevention of anginal attacks. They reduce the frequency and severity in classical angina by reduction of the cardiac work. They increase the exercise tolerance of the individual. Shorter acting DHPs may worsen the angina as discussed earlier because of the reflex tachycardia and reflex sympathetic overactivity. Verapamil and Diltiazem can be employed if beta blockers are contraindicated for chronic prophylaxis. Other therapeutic uses are calcium channel blockers are effective drugs for cardiac arrhythmia. Verapamil and Diltiazem are very effective drugs for the paroxysmal supraventricular tachycardia. They control the ventricular rate into the supraventricular arrhythmias also, like atrial flutter and atrial fibrillation. They can be useful for the management of hypertrophic cardiomyopathy also, where verapamil is used. Premature labor is a condition where the uterine contraction starts before 37 completed weeks of gestation, and calcium channel blocker will relax the uterine muscle also and can be useful for the treatment of premature labor, where nifedipine is the alternative drug. Raynaud's disease, where the peripheral vascular disease is there, so we use dihydropyridine to reduce the severity of the disease. Now we see the combined adverse drug reactions. Adverse effect can be divided into two categories. One is due to vasodilatation, that include headache, dizziness, facial flushing and hypotension. Ankle edema and gastroesophageal reflux disease can be worsened. It produces reflex tachycardia and worsening of the MI and angina, that is seen with the nifedipine immediate release. Constipation is very highly seen with the verapamil. Cardiac side effects are bradycardia, transient asystole and exacerbation of heart failure have been reported with verapamil. Rarely they cause urinary retention, rash or allergic reaction and increase liver enzyme levels. Important drug interactions to be remembered with the CCB are verapamil or Diltiazem with the beta blocker will produce cardiac depression and they should not be used simultaneously. Verapamil and Diltiazem plus quinidine, they would produce cardiac depression, should not be used simultaneously. Verapamil will increase level of digoxin into the blood, will require monitoring for that. So this finishes the important side effects related to the calcium channel blockers. I hope you have understood the topic, and if you have any questions, you can ask